Good evening, everyone. I hope that you can hear me. If you cannot hear me, please type into the question box at the end of your GoToWebinar sidebar on the right hand of your screen and let me know. You are all muted so that we don't have any distractions during the presentation. If you don't know, this is Diane Seeley. I'll be your host this evening. And tonight's topic is Therapeutic Intervention and Scoliosis in PWS. Before we get started, I just wanted to go over a few housekeeping notes. Please take a minute to write down the dial-in number and the access code for tonight's presentation should you become disconnected from the call. The number you would dial to get back to us is 914-614-3221, and the access code is 990-439-682. We will have a Q&A segment at the end of this presentation, so please note that on your dialog box on the right of your screen, there is a question box for you to type in your question, which we will get to at the end. Please do not use the chat box. I'm not going to be able to address them in the chat box. You can submit your questions throughout the entire presentation. We will hold everything till the end. Everyone, please be sure that your line is muted. I can't stress that enough so that everyone can hear the answers to questions. We'll be happy to provide any assistance with you. If you have any questions, please use that question box. And without further ado, I'd like to welcome Janice Agarwal. I've known Janice for a very long time. She is a wonderful therapist and has presented at many of our conferences for PWSA USA. Watched her son grow up and is now a teenager, the scary years. So I will hand it over to her at this point.
Okay, first slide. Hi, this is Janice Agarwal, and we're going to start with these are my little boys. This is Sam and Alex. Next slide. Diane, next slide.
Hold on.
Okay. So what we're going to do tonight is we're going to talk about therapeutic interventions, and with that, it's going to include some scoliosis. But in the beginning, what I want to do is some homework. This is a sheet that anyone can get, and it's a sheet that talks about some sensory integration and things that you can do with your children. I suggest that all of you go in and download this. I believe every one of you have a book that I wrote, and you also have this sheet of paper, but it gives you what a problem that you see, and it gives you a lot of ideas of things that you can do. And we'll go over some of this in a different lecture because tonight we're going to stick with the very basics. Next slide. Okay, keep going. For the first time, so what we're going to do is as I go from state to state and I'm working with more parents, one of the things I'm starting to begin to understand is when we started early intervention in the 80s and 90s, children were getting PT, OT speech 2, 3, 4 times a week. And that was considered the general standard of care. Nowadays, what they're doing is what's called parent guided, or they're trying to cut back on services. So I really feel that as I explain to more parents what each service is, why you need it, and how to fight for it. And we're going to explain why they're really important. I'm a physical therapist, and so I'm going to focus on your motor and sensory development. Most therapists, you're going to want your PT there day one. You're going to want them 2, 3, 4 times a week, and they're going to work on the basic gross motor development. They're also going to include sensory because your sensory and your gross motor run parallel. Next slide, please. We're going to be talking all physical therapy, so you're really going to understand what I do. I think the key component to our children, which is often missing, is speech and language therapy. The very day your child is born, they will need speech and language therapy. And why do they need it? They need it. Diane, can you go through 4 slides? I think I have it as the ideas of what speech is. Speech and oral therapy are really important for pre-speech, just learning how to move their mouth. Oral motor, and what oral motor is, and for those of you that have children prior to this child with Prader-Willi syndrome, they're always bringing stuff to their mouth. Our children, all children learn by bringing things to their mouth. But the other thing they learn is how to relax, when a child is really upset, the first thing they do is they bring something to their mouth they want to suck or they want to nurse. And that's how they start to calm themselves down. That is how children learn how to keep themselves calm. We will continue using that through our adult lives. You have people who bite their nails, or they put their hands in their mouth, or they chew gum when they're bored, or they suck on things when they want to listen. Our children are not using that sucking. So they're not learning how to regulate their emotions. They're not learning how to relax themselves when a situation gets tough. And that's going to be really important that they learn that, because later on, we have a lot of children that have behavioral problems. If we can come up with strategies at this very young age, and we can teach them how to regulate their behavior, how to calm themselves down, how to get themselves up when they need, how to be able to listen, how not to have a tantrum because they have just enough control that they won't. I truly believe that those are the kids that will have fewer behavioral problems with as we go on. And the other thing that's really important about that is think about how hard it is to sit and listen to someone. A lot of times we'll fiddle with things, we'll play with things, we'll bite on the inside of our mouth, we'll lick our lips. That is how we are able to listen to someone carefully. Our children oftentimes get distracted easily, or they have difficulty learning. If we give them these tools, starting with the oral motor, we have a greater chance to increase their cognitive growth. Now, the other part of this on therapy, speech therapy, is the cognitive. Because what happens is, first off, they learn to bring things to the mouth. They learn textures, they learn distance, they learn, how to obtain things. But as they're learning oral motor, and they'll learn how to create sentences, they'll learn how to back and forth play, they'll learn how to repeat, they learn the games. Though all those little fun things are what our speech therapists do. I believe this is one of the key person on your teams. And unfortunately, many of our kids don't have it. They believe that if a child's getting a G-tube, or they don't need the sucking in the beginning. And I disagree with that, or along with most good speech therapists. We do have a lot of OTs that do oral motor, feeding, and that's great. But you need more than that. You cannot get enough of this speech language therapy. Next slide, please. A visual is kind of a cool thing. I'm just going to say that, as you're learning to bring things to your mouth, you start to learn how far it is to pick up that object to bring it to your mouth. We forget how your oral motor and your visual are actually connected. Next slide, please. Auditory will go on to occupational. Next slide. The next group of people is our occupational therapist. And our occupational therapists are going to be responsible for those finer motors. They're really going to be responsible for sensory. Now, one of the things I have found is that many parents say to me that they've spoken with their occupational therapist and they do not believe they have a sensory issue. And a sensory is how you tell your muscles what to do. So the sensory is your brain connecting to your hand, knowing what your hand is doing and telling your hand to go do other things. Because our children are not moving, especially in utero, every single one of our children have significant sensory issues. The problem is they don't declare themselves until they become behavioral problems. They don't declare themselves until they're too far along. But because we know our children well, we recognize now that you want to start sensory as soon as possible. The deep massaging, getting in there, letting them feel their bodies, putting on weighted vests as they get older, trying different textures with them and different flavors and all the different sensory delights that we have. We want to start them as early as we possibly can. And your occupational therapist, you need to encourage that again and again. They'll also continue to work with gross motor and the speech. I can't begin to tell you how important it is to have your therapist communicating to each other. I think it's the coolest relationship you can have, to really find the therapists that work well with your family. And what happens is they start to get to know your family well, and they start to realize where your strengths are, because not every family dynamic is the same. Some families are going to have strengths in one area and some families are going to have strengths in the other. So as your therapists get to know you, they can start coming up with something to do that is one of your strengths that you can help your child, or how they can interact with your other children. every time you meet with a therapist, you need to write one thing down that you can do before the next visit. And I suggest you write those things down so that we don't forget them and lose track because our lives become so hectic. And you want to pick one thing that you absolutely know you can do. Okay, so we're now going to go with the motor skills. Next slide. Okay, we'll just go through the occupational. They work on fine motor, ADL, sensory. So pediatric physical therapists, we specialize in examining, evaluating, treatment, and the overall management of our children. When we're looking at your children, we're not only just looking at their muscles, we're looking at their spine, we're looking at how their limbs come together. We're going to be looking at their hips because we have some kids with some hips dysplasia. And we're going to talk to you on how we can, on a lot of our children, prevent the scoliosis and hip dysplasia, or actually, if it's already started, we can work on trying to minimize that. Next slide. So we're going to be improving, let's just go through these, gross and fine motor skills. They're going to work on balance and coordination. Balance starts in utero. So we want to be working on swinging your child. You want them to be constantly moving. We learn balance from constant moving, spinning, rocking, and all the things that we normally would do with our children. You can't stress enough the rocking and that goes on with children. We work on strength and endurance. Our kids we have the coolest kids ever, and they work really, really hard, but they do have a slow endurance. So the reason you want to work on a recipe with your therapist is sometimes our kids can only handle 10 or 15 minutes. So I have parents who will say to me, well, my therapist comes out for an hour. I would rather a therapist come out for 2 half-an-hour sessions than 1 hour session when our children are very young. And the reason is our children can't handle a lot. So you want your therapist to go in there with intensity, and you want them to work on skills that maybe you can't, so that when they're done, they can pass on to you something that you can do. If they come in for a 1 hour session, I don't know a single baby that can handle a full 1 hour. Not a single baby. So we want to work on more sessions, more frequent sessions than longer sessions. Next slide, please. We want to work on, I'm just going to say learning experiences and go with that, but you want your therapist to integrate with their family. And I love when we bring the other kids in it and we can make it a family experience for everyone. You know, the other thing I always say is moms, dads handle babies differently than moms do. Dads are a little rougher. They don't always read the baby, and we need to let the dads do this. I love how dads interact, kind of roughhouse with babies a little bit more. You know, walk out of the room because they cry, they laugh, they cry, they laugh. But what is great about that is they get older and they do more roughhousing. That is such a positive thing for our children, that you'll find that your kids, when they're around, they want to be with their daddy. They need that stimulation. They need that input. We think we have these really, really frail babies. We have babies that need input, and they need a lot of input. And as they get stronger, you will know that they are significantly less frail. They're just a little weaker. So let the dads, you know, my husband would throw them up in the air, do the flying naked baby thing, and I would just walk out. And my kids would be, again, I didn't know if they were laughing or crying, and I didn't care. That was my chance to get away and let dad learn how to take care of the baby. Next slide. So continue. The early benefits. These first years are the most critical years, which is why I want you to get all these therapies on as soon as possible. When a baby comes out of the hospital, they should have all 3 services set up. And that's how it used to be, by the way. And as many as you can possibly handle in your family situation. I don't care about the ages that a child hits a milestone. What I care about is that they hit those milestones. Infants develop in the exact same way. So we want all those milestones to be hit in the absolute highest standards. So if your child doesn't get their head control till 6 months, that's fine. I don't want them sitting up at 9 months. Then they're going to go back down to being on their belly. It's really important that we hit all those milestones, not the ages. Next slide, please. during these years, the children are going to achieve, this is for exponentially the most that they're going to grow. I love, this is the time when you're talking to them and they're going to learn to start imitating. They're going to see what you're doing. They start absorbing all of that, and that is their future. That is these first year or 2 or 3 determines pretty much how your child's going to turn out, how you handle their behaviors as they get a little naughty at these, or when they need that security and you just need to cuddle the baby because they're crying so that they can learn to emotionally control themselves. When you ask for just one more, you say, okay, we're going to do one more time, and then you take a break. They're going to learn that when you say one more, it means one more, and that's okay. And then after that, they get a cuddle. So these are the years that we define our parameters with our children, and they start learning how to be successful. Next slide, please. So we all know that our kids are hypotonic, and that's really important, that hypotonicity and weakness go together, but they're not the same. We're going to be working on strength. They really are truly going to be slightly hypotonic the rest of their lives. But as their muscles get stronger, that will strengthen around those joints, and that's what gives their security and structure and allows for higher levels of development. So we really do need to work on strengthening. We do know with growth hormone, it decreases a lot of that hypotonicity. So I'm a big fan of that. So this hypotonia means that because our children can't do as much, we have to bring everything to them. We have to bring things to the mouth. We have to teach them to bring their feet to their mouth. We have to bring textures to their mouth so that they can learn to explore in their small little world as they learn to walk out of that small world. You want to bring everything to their mouth. You want them to learn as much as they possibly can. You want to give them lots of different, I love at this age, start giving them like flavors, putting a little bit of lemon on your mouth, on your finger, and putting it in their mouth, letting them have lots of different textures and letting them that have a little bit of flavors so they can understand what that is. Slide, please. Due to hypotonicity, they are going to experience delays in their developmental patterns. And this is the thing I will constantly say this. They need to go through the development. Parents are like, I want my child to stand by 1, or I want them to sit. And I'm like, no, you need to get them on the ground first. And they need to explore the ground, and they need to creep, and they need to crawl. These developmental patterns will be the things that help structure their shoulders, their lungs, their lung capacity, their ability to do things is all in the way you develop. And all babies, we've studied development again and again, and that's a really important thing to learn. I, as a parent, I, as a therapist, I've watched it for years. I understand the pain. I understand how it hurts when your child is delayed. I get it. I also understand that if we take our time and work through that, we will have a child who is higher functioning and goes on to be just an amazing citizen in this country. Our kids are rock stars. Our kids are rock stars, and they're capable of doing so much, but we have to have the foundation. It has to be a secure foundation. Next slide, please. We want to do it on their timetable. Next slide. Continue. So the first one we're going to talk is head control, and this is the first movement with our infants. So, and we need that. So we want to make certain that the last part that actually our babies are capable of strengthening is actually the front of their body. The front of their body is called your flexor muscles. And so our kids, sometimes when they're on their bellies and they're holding their head up, that's actually just leaning on a bunch of ligaments. So we want, in order to get good head control, what they really need is to start to get the shoulder control that's there. The head control is the most important part of our children. So we want to make sure that structurally, before they come upright, that their shoulders can control that. And why is that really important? For several different reasons. Not only will that be imperative that they get good swallowing and that we don't aspirate, that they're able to breathe better. They get all those axillary muscles that are up there. But the other issue is for feeding. for oral motor, for talking, for a lot of the things that they're going to do in upright. The stronger their shoulder and head are, the greater the ability for them to do oral motor stuff, to do language skills. But the key here also is a thing called head writing. And a head writing is when a child starts to fall, they want to save their head. They want to be able to pick their head up. So if they cannot control their head, they don't know how to protect their head. And we're going to give them an increase in fear. So those writing reactions will come with their arms, and it comes with their head. So the more ability we give them to strengthen their neck muscles, we're going to decrease and diminish their fears of wanting to do higher level skills. Next slide, please. So that's the first thing we develop, and they develop their neck and their shoulders. The shoulders and neck we often don't think about, but as we look farther on, when we're looking at occupational therapy, when we're working for like fine motor control with writing, or the pincer grip, or to be able to hold spoons, or do coloring or different tasks, we need that neck and shoulders. We especially need those shoulders. We found years ago that we stopped putting kids on their bellies because of SIDS, sudden infant death syndrome. And what we found is because those kids weren't getting shoulder strength, that we started to see more occupational therapy intervention needed, because they didn't have as strong hands. But the other thing they didn't have the same respiratory, because their chest muscles were not going to get as strong. So those kids were kind of behind. It's an interesting thing on that one. We actually saw an increase in some kids with asthma-like qualities. So was the asthma because they didn't have the trunk and neck control, shoulder control? We don't know, because as those kids get older, a lot of them just outgrow it. But there's got to be something that could potentially be related to that. So we really want to work on those shoulder control. Next slide, please. So it also, again, future development of the fine motor. Next slide. The writing reactions. Those writing reactions, what I was saying is, as they begin to fall, as you begin to fall, you start to throw your hands out and you start to hold your head up. Think about when we're falling down, you naturally try to protect your head, whether you're going to the side or the back or the front. And that's how we start this whole thing. Next slide. Rib cage. Well, I can't stress this enough. A lot of our kids have respiratory issues. Your rib cage develops on your belly. When we're born, our rib cages are very high and we have very shallow breaths. The more we lay on our stomach and the more we start to bring our head up and our shoulders up and put hands on our elbows, that strength starts to move down and those rib cages start to fall downward, and we get a better pulmonary respiratory rate so that we can take deeper breaths. Your best quality of air comes from your lower lungs, and you don't get that until you have that rib cage control. Next slide. One of the ways I love to get head control with our children is by placing them over a pillow, which just kind of forces their head down, and it forces them to try to kind of pick their heads up a little bit against gravity. And then as they're able to do that, I try to lift them up a little higher, and then maybe put something out in front of them that they can grab onto. Or you can bring their arms out in front and start having them kind of putting their weight on their elbows and then on their hands. So we have a lot of little toys. That's also a wonderful opportunity to teach your child while they're kind of propped up on that pillow to grab something with their hand and try to bring it to their mouth so that they start understand how to explore their world around them. We need to teach our children how to do this, because in the beginning, when young babies are born, they start to learn to do this as they are able to move more. Our kids are not going to be doing that as much. So we're going to encourage them to learn it by having them hand over hand do that with us. Next slide, please. I love rolling side to side. So one of the things you can do for head control is while your baby is on their back or on their belly, you just kind of take their legs and you cross them over and you go from one side to the next side. The baby in the beginning, they seem kind of floppy. But what happens is our natural reaction when we're kind of moving around too fast is to naturally stiffen up. So what we're going to be doing is encouraging our children to learn how to tighten up those muscles that they really truly don't often know is there. And that their head has to follow. But now be really careful with this one. Once they start to enjoy this, they're going to want you to do it again and again and again. And that's kind of a fun thing, because then they start to learn to giggle and laugh because they love that. That is also in the long term going to increase their balance, because that's a vestibular thing. It's moving their head. And once they realize that they're not afraid of it, they're going to love you doing this, and you'll start rolling them over and over again. It's a really fun thing to do with our kids. And again, once they learn to love it, you won't be able to stop. Next slide, please. Pull to sit. As they get a little bit older, this is something you can do. Like I said, the very front of their body, those are called their flexors, are the last things to happen to get stronger. So grabbing onto their arms and just slowly bringing them up a little bit, not all the way, but just allowing them. You really need to look at your child and go, when do they get a little bit of control? And as soon as they lose control, you want to bring them slowly back down. You don't want their head just banging backwards. But slowly but surely, as months go by, we're going to see that they can start bringing their head forward, and they'll really enjoy that. And they can start looking you in the eye, and you'll start seeing that strength. That's a really important strength for these kids to learn. Next slide, please. I love bringing feet to mouth. So when they're laying on the floor, what I love to do with babies is just putting them in between my legs and just playing with them and constantly bringing their feet to their mouth. Our kids don't always do that on their own, but normal babies do. So we want to encourage that, and it achieves several different things. It helps them learn to explore, but it helps all those flexor muscles right in the front. As you bring your legs up to your mouth, you're going to get all that strengthening going on, not only in your trunk, but in your legs and in your arms. And once they start learning that, they start bringing things, and you'll start seeing visually, they know how far things are. They're going to learn different textures. They're going to start learning about their environment. And I love doing this, and it's a fun thing, intimate thing to do with your baby. Next slide, please. Sitting. The ability to sit, to maintain a sitting position, requires that they have a strong neck and back. I believe that no child should be put in sitting until they're able to almost do it themselves. So a lot of moms ask me, but then how do I feed them? So we have high chairs that we can put kind of rolls around and keep it at a slight angle. So we don't want it to be all the way upright. For feeding our babies. Please go to the next slide. But I think we all need to be really careful about this. In sitting is when they're going to develop more of their equilibrium reactions and protective reactions, and they learn side to side. But we want to be really careful with this. And it's the number one question I seem to have from a lot of families is it okay for my child to sit? And I bring this up first because it seems to be the number one question. We have to think about a pole in the ground, and a pole in the ground, unless it has a nice firm foundation around it, when the rain comes, it's going to bend to a side. So if our children don't have that nice trunk control, when they're sitting, they're going to flop over or they're going to flop to the side. And that's going to encourage the balance in their muscles not to grow, not to be challenged in the same way. So we'll have a child who's asymmetrical. And that's how I think we encourage some of the scoliosis going on. Some of the scoliosis that goes on is just idiopathic infantile scoliosis, which just means because we have hypotonic children, they have scoliosis. And truly, most of the scoliosis can't be really declared until a child is standing up. But we want to encourage the sitting only with support until they're ready. Next slide, please. Continue. If we're going to bring them up when they're playing, I always like to have pillows. But I think the most important thing we're going to do with our kids, and I really can't emphasize this enough, was creeping and crawling. So creeping is when they're moving on their bellies, kind of like a snake, you know. And you'll see kids creep on the belly. Some of our kids actually creep on their backs. And if that's their way of moving from site to site, I'm not totally against it as long as we're encouraging them and we're constantly moving them over to their bellies so they can learn on their bellies. The back, like I said, their extensors are their back muscles. Those mostly are ligaments, and they develop almost when the child's out of utero. So our kids are compensation kings. And what they want to use is the muscles that are the easiest for them to use. And that means that they'll be back crawlers. We want to really discourage that, use it for a little bit to get them places, but constantly redirect them and put them on their bellies. And then once they go from that and get going from objects, next slide, they go into what's crawling. A lot of our kids don't like to crawl in the beginning because they don't have the shoulder arm strength. So you can see why once they learn to crawl, when you have a child who is crawling everywhere and you can't stop them from crawling, they will naturally start going up to furniture and standing. You don't have a choice but to let them start going to walking. But as long as they are crawling and moving around, what you're doing is you're allowing the opportunity to get all their shoulder strongs, all their arms, their hands, the little muscles in their hands, their legs. You know, it's interesting. We've got a lot of kids with hip dysplasia. And a lot of hip dysplasia is caused because when a child is forming, the way the ball hits the socket in the hip, it starts to alter and change. So as they come up to their shoulders, it starts to, because it's really just very pliable, it starts to change. And as they start to move to crawling, what you will see is that the angle on that ball starts to change. And that's how and then the socket on that ball starts to change. So it's a really important thing for crawling to kind of decrease the chances of hip dysplasia. The other thing is it's allowing our children's spines to develop in a very symmetrical, almost anti-gravity situation. And that's a really important thing because they're going to become more symmetrical in their back. As they become symmetrical in the back, we decrease the chances of scoliosis. Over the years, and I've been working with kids with Prader-Willi syndrome for about 19 years now. Over the years, some of our most hypotonic kids that would have 40, 50 degree scoliosis before they were ever able to sit and stand on their own, we would keep them and we would talk to the parents and say, keep them down, keep them down, keep them down. And it's a really discouraging thing from the point of, oh, all my kids are walking. But the longer you keep them down and the stronger their trunk becomes and the stronger their shoulders become, the scoliosis seems to diminish. Right after they're come to sitting and they've got nice strong trunks, I tell you to get them on a horse for hippotherapy because I think that's one of the greatest therapies out there. Next slide, please. This is my most important slide, though, creeping and crawling. It's the most important slide. Again, you hear my dogs in the background, and I'm trying to text my husband to get them out of here, and he isn't really listening, so I apologize. So I'm going to make one. So I apologize until he comes and gets them out. So I think the infants, the postural control that you get in creeping and crawling is probably the most important thing you do. The next slide, please. The other thing is we were talking about protective reactions. And with those protective reactions, when you start to fall, when you, like even in sitting, you start to fall forward, you will see a child take their hands and move them forward, and then and then they go to the side, and then they go to the back. They can't do that unless they're nice and strong. And that's what they're going to get with creeping and crawling. And again, I'm going to apologize in the background noise. My family forgot that we're back here. So the infants develop postural control. They develop balance. Next slide, please. And locomotion. So the locomotion part is when they're in crawling, they learn their pelvis. So the pelvis in crawling starts to rotate the way their legs are moving. And that is going to carry forward as they start coming upright to walking. but they learn that in crawling. I think you learn as a child, the creeping, crawling situation is the most intense. They learn the most in that. They get the strongest, and we diminish the chances of scoliosis. We increase the chance of pulmonary. We learn all our sensory, and we get all that symmetrical kind of growth in the trunk. Cannot stress that this is my favorite area. And I want parents to keep their kids down there until you absolutely cannot keep your child down any longer. Next slide. Manipulation. Again, we were talking about the stronger those hands become, the better their fine motor becomes. And you cannot get good fine motor without good hand control. And it's a funny thing. We're really seeing a change. I'm just going to tell you, this is the greatest time to have a child with this syndrome, because all the stuff that's coming out. It used to be when you looked at our children with this syndrome, their hands were chunky and they couldn't move them, and they really didn't have good manipulative hands. And now I look at my young kids, and you almost can't tell the difference sometimes as they get older. Once they get out of that creeping, if you've got a parent that really works on keeping these kids creeping and crawling, the hands get so strong, you can barely tell the difference between our kids' hands and anybody else's hands. I love that. Next slide, please. So up until this time, infants have been working on head, neck, shoulder, and back while on their stomachs. Next slide. As they increase, the ability to look around and reach out and touch objects becomes easier and easier. And then, of course, we have to start worried about things that are way above crawling area. Next slide, please. So continue. Next slide. So the next thing we do is we can't handle it anymore. They're going to come full to stand. And once an infant develops the strength and coordination to do this on the floor, they'll want to stand. You really want to make sure that they have those protective reactions, that they can kind of reach out and protect their head if they fall forward. They may not have it to the side or the back. And if those kids, I encourage you to have, I love big air mattresses or mats or things that if they do fall, they fall onto and they don't get hurt. We do not want them to know the fear of hurting their heads in the very beginning, so that as they're learning these delayed protective reactions, because that will set them up for fear as they go on to higher level skills once they're starting to run. Continue. That is my son, by the way. He's so cute. Continue. So initially, they start with your child coming into a high kneel position. That won't last very long. At this point, we're going to talk a little bit later, but this is the point, parents, that you think about orthotics. We're going to talk just a tad at the end, but as soon as these kids come pull to stand, I want something on their feet. No matter what, all of our kids need something on their feet as soon as they go to standing. Because of the hypotonicity, we want to make certain that their feet are hitting the ground correctly so that their ankles, knees, and hips are all aligned correctly. Next slide, please. So I love, parents ask me how to do this. What I love to do is put yourself behind your child, and you want to make sure that their hips are even and balanced. If their pelvis is balanced, again, the scoliosis means they've got nice balance in their back so that we can learn to develop our spinal muscles correctly. And the other thing is I want something on their feet so that I know that they're on both feet correctly. Their feet, ankle, knees, hips are nice and aligned, so they learn how to shift from side to side. Next slide. As they gain strength, you will see that all over, as they get more strength in their trunk, they're going to start to cruise. And that's just a natural progression. Once they start to cruise, they're off. That's the best part. Keep going. So walking. To help with walking, every child needs orthosis. What I have in this picture is you will see the difference of a child without orthosis, and you can see how their knees are slightly bowed. As soon as we put these orthosis on, you see that it's a lot straighter. But what it also is their feet. Their feet tend to turn in, and they tend to like on the medial aspect of it. And that is not the best way to get the most effective walk, because we want them to walk from heel to toe. They're in the beginning, they're flat footed, but we eventually want them to go to heel to toe so that they not only learn to walk, but they learn how to run and jump. If our kids compensate, if they learn how to walk incorrectly in the beginning, it is a really difficult thing to learn how to teach them to walk correctly. So we want those orthotics on right at the beginning. They do not need them on for long. I mean, it's going to be a year or so. Really, every kid is different, but many of our kids, we start taking back the orthotics because we want less. The more they give us, the more strength they get, and the more they're doing, we want them to encourage more strengthening. So we want to take back some of that orthotic. So they'll go from something that's a little above their ankle to just a small insert into their shoe to eventually just a nice shoe. We want to encourage them to use less and less stuff because they can and will become more and more independent. Continue. Children tend to walk with their feet wide apart and their knees are very stiff. They're leaning on their ligaments because their muscles are weak. One of the things I love to do when our kids first start walking is to put something in their hands. I don't fully understand why this works. I kind of go with it. If we put like a little ball in their hand, it gives them the trunk stability that they need so that they can walk better. So if you want your child to take a few more steps, let them hold on to something big. Later on, what you can do is you can put water and bubbles in those balls so you can take their balance off when they get a little bit higher functioning. But giving them something nice and big, a stuffed animal that's a little bit bigger. But I really like balls because it keeps their arm support out there. So they've got that big base of support up top so they don't have to wobble over their base of support on feet. They tend to lock their knees. And you'll find that once we put them in their orthotics, that will change how they walk. They'll start bringing their base of support in a little bit more, and they tend to flex their knees a little bit more. And I think that's a really important thing to note. It's normal to start with a wide base of support, but as they get more refined, it gets smaller and smaller, and they will start working on trying to put some weight on that heel, and that's when you want to get rid of those orthoses or minimize them. Next slide, please. So to help with walking, these orthoses are a thing called Sure Step. A lot of our kids have them. There are other companies that have them. They're very, very thin. I don't like big, thick stuff. And the reason I don't like big is because our kids compensate. They compensate so much that anything you give them, they're going to use. We want to give them just what they need to get the task done, nothing more, so that they're learning how to build their muscles. They're about the thickness of a 2-liter bottle. The theory was an engineer who came up with the idea of Coke in a 2-liter bottle. Once your body is inside of it, that is the stability that they need to keep that orthotic strong, but yet it's still flexible so that they can bend it so that we give them more function. Oftentimes with the really, really thick orthotics, first off, they don't feel the ground. Because the orthosis is so thick, they don't have a good feeling for where their feet are. And I don't like that. And sensory-wise, our kids are already having issues. But the other thing is it prevents them from just moving like a normal child. We want them to move as much as we possibly can. Next slide, please. So continue. We would talk about it. Just again, we have more pictures of overpronation. And then after the kids are walking, I love to just continue expanding their skills. I love small trampolines, large trampolines. I love running. I really love hippotherapy. Hippotherapy, when they're on that horse, if you've ever ridden a horse, you will see how hard it is to get your trunk nice and strong. I love swimming. I love any kind of activities that we can use with our kids that are fun. Next slide, please. Any questions? The whole thing about this, you guys, is we want to have fun. We want to integrate it with our families. We want to get our children the therapies they need, but we want to do it in such a fashion that they follow the normal milestones. I'm trying to leave 15 minutes. I just want you to know that if this works out well this time, I think we need to do some more webinars, but we need to be a little bit more specific. This is a basic foundation of how a child develops. What I want is to be able to add some sensory components and add higher functioning skills, look at some problems that we have. And these are things that we can do later on. But I think today, this was just a foundation for our babies. First question.
Janice, we do have a question. Mom is curious as to with butt scooting, where does that fall into? Is that along with the scooting, crawling?
Well, I'm hoping that if they're butt scooting, they crawled first. So if they didn't, I would encourage both, because a child who's come up to butt sitting is already seeing the world from a higher perspective. So I don't want to discourage that, but you need to have those upper arms that are really, really strong, because if they fall forward and they're not reaching out on all different directions to protect their head, then when they come higher, they're going to miss the higher level skills that they can attain out of fear. And that's one of the biggest things I've seen in our kids that are 2, 3, 4, is that they don't have those protective reactions because their arms are not strong enough. And so they're not willing to learn how to jump or run or do all those fun things. They shouldn't get delayed in those. So I don't have a problem with butt scooting as long as their arms are really strong and they've done the crawling. If they are doing the butt scooting and not just, again, you want to encourage it, play games like wheelbarrow, where you kind of hold on first to their pelvis and eventually move out towards their leg so that they can walk on their hands. Or what you can do is you can put them on a bolster or on the couch and have them play with toys on the ground where they have to put weight on one arm. You want to encourage weight bearing on those arms.
What about cruising? I've had some folks say that cruising isn't a necessary step. Is that true?
Cruising isn't walking?
Cruising as in like cruising along the long furniture.
I love cruising. Cruising is a natural progression in children. And I think that I actually prefer, because our children are delayed, and their shoulders, again, their trunks are the weakest part. Children with Prader-Willi syndrome develop differently than most children. Our children, their strength is in their extremities before it is in their trunk, which is why we see so much scoliosis and respiratory and oral motor issues. When they come up to stand, if they're working on cruising, they're still working on their trunk control and the security of that. And I think there's a lot to be gained by that, because they're going to learn to move around and do things without having the fear of falling. And that allows more exploration and learning from that. The only concern I have is, again, you really need to make certain that trunk is strong, because if it's not, we're looking at the inability to do higher functioning skills. I keep coming back to make sure the trunk is strong, make sure the trunk is strong. If they're cruising and it's not, we can work on balls. We can work on different things that are fun. You can work on trampolines. But when we're working on those higher level skills, like on a trampoline or something outside where they can hold on to something, I would put like a girl's bathing suit or some kind of suit that gives them a tightness around their trunk. It's a proprioceptive suit, and we haven't gone into that in this lecture, but proprioception is the ability to feel your body, your muscles. And women know that when we put our hose on after the summer, you know how you feel your legs when you have tight hose on in the beginning? Well, that's what happens with our young children when we put tight clothing on them. So if I'm going to have a child cruise around and I want to work on trunk strengthening, I might put a really tight t-shirt on them or a tight girl's bathing suit on them. Or we have a lot of body suits that our kids can wear, or take spandex and put some Velcro on the back and make it kind of tight. And what you're going to do is you're going to give that child the awareness that they need so that they know to engage the muscles around their trunk. And that's a really important thing. And what you'll see is once you start to do that, you'll see them start trying to bend their bodies in different directions because they feel them. Oftentimes, they're not moving things because they don't know that they are there.
We have another question. Do you have ideas for encouraging responsive reactions in a crawler?
What do they mean by responsive reaction?
I know you were talking about that writing reaction, maybe.
Right. Okay. Yes. So this is all about fun. This is all about fun. So one of the things I love to do is when a child, I put them in between my legs and I hold on to them on their hands, right? And I pound their hands on the ground in front of them and to the side. And I go from side to side. And what I'm doing is I'm letting their hands pound onto the ground so that they get that feeling of what it's like to go through their hands. And we play games with that again and again. And what it does is it stimulates the muscles to they start firing off, and it stimulates them to react. And what we're doing is we're teaching their arms and hands how to react when they hit the ground. And if you continue to play with a child and then you let them do it after a little bit, that protective reaction will slowly start to come in. But it's literally hand over hand teaching them. You can also do that when you're holding on to them. And if you bring their head forward onto the ground, sometimes they'll bring their hands out. What you can do is bring their hands down to the ground. And you kind of have to put, it's kind of, you have to be an amazingly limber person, but you want them to understand that when their hands go, they need to reach the ground. But I love to do it right between my legs with them sitting between my legs, and we're laughing and laughing. And I'm like, this is the way we pound our hands. Up we go forward. Up we do this. Catch yourself. And we do it forward, and then we do it to the side. And eventually, once they get it, then we'll learn to do it backwards. But we want them constantly doing that. And kids will naturally learn to do that once you've taught their hands how.
We have a mom that writes in, since my PT says it isn't necessarily essential, how do I promote cruising? I have a BSN Kinsio, but this is out of my league. We also just received a DMO suit. She is not interested in cruising at all. She's 22 months.
So she's not even standing? So I love the suit. Okay. And when a child is ready to cruise, they'll cruise.
She is standing, by the way.
She is standing. Okay. So this is where fun comes in. So then you put together a PlayStation, and you put the suit on because that's going to give her support. And then what I would do is I love like little kitchen stations or little stations where they can sit there and they can go side to side and do fun things. And what happens is they start getting so comfortable in that little area, they'll move outside that area to take something else. We don't want to scare them. We want to encourage them with playing. So, you saw the picture where her standing. What we did was we put straps so that there was a security that no matter what happened, there was no falling. And with that security, we allowed him to slowly go side to side and play with things on the couch, play with things on a small table, and just let them spend a lot of time doing that. It's really okay. And I can always talk to a therapist, but part of this is cognitive. It's a child learning to play and explore their environment. And we want them to learn to play and explore their environment. Not everything is about a milestone when it comes to motors. A lot of it is our kids are all together. We got to think cognitive, language, fine motor, gross motor, sensory, all together. And so which is why you want to have lots of toys that allow them to do a lot of different things. They learn to explore and have fun. We want it to be fun. We want it to be a growth thing. One of the things I love to do, I put magnets and stuff that they could play on refrigerators, and everywhere they went, I had things that allowed them to stand and kind of play with things and move around. And slowly they will do that if you give them the security of that. I hope that works.
We have a mom that is facing surgery for hip dysplasia,
Yes.
and to know if there's a therapy protocol while she's casted.
Yeah, I'm bummed. That's a bummer, but that's okay. Well, they're in a cast. So what will happen is kids are really, really adaptive. This is an opportunity for you to get that child's upper extremity so strong that when they come out of that cast, they will have the strongest trunk and upper extremities in the world. And if you do that, they will start moving themselves. She, I think you said, will start moving herself around with her arms. So I'm going to take this as a positive thing. Usually when we have our kids in those casts, they really get strong upper extremities. So this is a time to just decrease your stress. You're always going to feel guilty. You're always going to have stress. Decrease it. They're going to be in a cast. That's the way it is. But take this time to do all upper extremity stuff, because that is more important than anything else you can work with your child at this point. So get over the stress of the cast and just think, how can I get them stronger upper extremity? I can work on oral motor stuff. I can work on respiratory stuff. And how can I get them to mobilize themselves on the ground with their cast? Kids are amazing. And our kids work harder than any other kids.
Same parent asks, we used to have sure steps, but now we have articulating AFOs. Are these good?
Okay. Yeah. That's up to the therapist, and I'm not there. So you won't need them for a while right now. And when the child comes out of the cast, that probably would be a good thing. So usually the therapist kind of sees what's going on, and they decide how to progress. And I tend not to say whether something is right or wrong when a therapist recommends it, because they're the eyes on the ground.
Mm-hmm. Mom writes in, our speech therapist only focuses on feeding. She's 1 year old. She's just starting to babble. Do you recommend fighting for language therapy? And if so, how often do you suggest sessions just focused on speech?
Okay, so speech babbling is speech. If she's working on oral motor, she's working on the muscle, and she's working on bringing things to the mouth. She can ask her, say, one of the things I was listening to is that a lot of these kids don't have good suck, and they don't have good ability to calm themselves. They never learned that. Are there things we can do? Are there things we can do for blowing and sucking and different things? Again, I don't really know what the therapist is doing, but they may be doing just what they think is the right thing to do. We have a therapist. Her name is Stacy Hiller, and I think we need to work on doing this with her, because there are some fun things you can do at home. And I'm going to talk to Stacy, and we'll write something up. But if you're getting oral motor and she's doing feeding, you're ahead of the game, because all of those muscles are together, and that's going to really be helping your child. Babbling, that is speaking, that is language. They go together.
Same mom wants to know if you have any specific or different recommendations for a child who already has scoliosis, not yet standing independently or standing.
Okay, so so you need to work with your therapist, and what you can do is you start strengthening the side that the curve is on, the longer side, and you start stretching the other side. You're working with a therapist, they can start working on getting that trunk nice and limber so that they can strengthen those more bilaterally. And then this is a great time to get a child in water therapy, hippotherapy, things that are going to allow symmetrical strengthening. But you need to get that limber, because they're not standing. The bone on bone that you do when you stand, that means there's no deterioration there. So it can be resolved, most likely. That's not always the case. But this is also a time I'd probably make sure they have a proprioceptive suit, some kind of suit, so they get good input into their body.
So that's a great segue into the next question. Any thoughts on pool or aquatic therapy?
Can't say enough about it. I think it's probably one of the best things you can do. It's fun. It's gravity lesson situation. So the kids, they're free to move, and it's very symmetrical. I had my kids, a lot of people I know love their kids in the pool, and they do really well. By the way, my son had the second fastest backstroke in Indiana. Special. That's just a small bragging.
You're allowed. Another mom says, my early intervention team is talking about trying to get my 9-month-old son adaptive seating, high chair. He definitely wants to sit up and see what's going on around him, and he's much more alert when he's propped up. But since he just learned to roll from tummy to back.
Yeah, so this is a question I get a lot, and that's why I always bring sitting in. As long as it's adaptive, as long as they have something on both sides of the trunk to keep it nice and strong, and you don't do it for long periods of time until they have the head control. We want to encourage tummy time on the ground, but especially with our feeding issues, we need kids sitting up a little bit. Because of how they've got such weaknesses there. So I'm not against it, as long as we know that the objective is trunk control on the ground symmetrically, so we don't have to worry about scoliosis, and so that we have kids, when they come upright, they're balanced. So it's a fine game you're playing, but you play the game because it's good for kids.
Next question. My little one doesn't sit on his own yet. How much supported sitting is appropriate with chairs, props? And is tripod sitting good or bad?
If he's getting up to tripod sitting on his own, that's brilliant. If he's not getting up to tripod sitting, I'd get him on his hands and knees crawling more. Because if he's not getting up on his own, his shoulders are not strong enough. And so then all the stuff we've just spoken about becomes a moot point. We need those shoulders strong enough so that he gets himself up into that position. Otherwise, I know it's hard to do this, and I know they get upset. But eventually, again, this is why we're talking about kids learning how to calm themselves. What they realize is that they're on the ground, and they have to learn how to start playing with toys, and they learn how to calm themselves down. We're giving them the tools to play and learn. Again, unless they're getting up to sitting by themselves, and unless it's a situation where we just talked about a chair, adaptive chair, I really, really believe you need to allow your child all the time on the ground that you possibly can get. You cannot get enough time on the ground.
We have a couple just suggestions from a mom who is a physical therapist and says that she does work in the pool with her little one and uses a wetsuit so they don't get too cold. And I know for many of our kiddos that temperature regulation kicks in, and I know my son cannot be in this pool for very long without getting very cold and lips turning blue. There's a suggestion for Theratogs or neoprene suits to use.
Absolutely. Awesome mom. Awesome PT mom. There you go. They have a lot of toddler classes, baby classes. I know we have one down the road, and those pools tend to be a little warmer, but that's a brilliant idea. And the other thing I like about that, is, again, our kids don't feel the world the same way. So when you're putting that suit on, they're going to feel their bodies. And that's a brilliant way to get them to feel their bodies.
So when is it I'm sorry.
Go ahead.
Is it appropriate to use a Theratog or a Benec vest or something like that?
It's always appropriate. Our kids can always use them because, again, our kids have a poor input. They don't feel the world the same way we do. So when you're putting that nice suit on them, which is kind of thick and it's Velcroed so that it's a little tight, they're going to feel that. So you would use it for a couple hours, take it off so they don't adapt to it. And then later on, you put it back on again. You don't want to wear it all the time. And the reason is, again, they start adapting to that. We want them to feel their muscles, use their muscles, take it off, let them use them on their own, put it back on. So, and the same thing, I love tights. I love putting tights on kids because they can feel their legs and let them go about and crawl about. And then you're teaching them how to take their tights off, and they take them off. And then later on, you have a game and you put them back on. That's doing a couple of things. It's teaching kids how to dress and undress, and it's also teaching them how to feel their bodies.
So this next question is probably for an older child, but is bike riding a good sort of therapy?
Absolutely. So, they have those little tricycles now that even have the pole on the back.
Mm-hmm.
When they're sitting, you want a seat that is a stable seat. So you want the kind of seat that has a back to it in the beginning. And you really, and I can't encourage this enough, you really want to make sure they're seated in it correctly. So, you can take some duct tape with little washcloths and put them on either side so that they stabilize that. But it's great for their legs. It's a great thing, and it's fun. I want you to have as much fun with your kids as possible.
That looks like we have addressed all of the questions for this evening. Lots of great questions and suggestions as well. Yes, I echo that. Please have fun with your child. We spent quite a bit of time on the floor with Reagan. I don't think we held that child as much as we just made him play on the floor, and we all got right down on there with him. With a large family, it worked perfectly.
And even with a small family, it works perfectly. I think if the families are interested, I think this was just a basic lecture. But I think we need to take this a little farther, and we need to go into different areas along with the sensory and things. And if they're interested, we can do that. They just have to talk to you because you're the
absolutely.
keeper of the web. And now that I've done one of these, I kind of have an idea how we can change it. But thank you for listening.
Great. Thank you, everyone. And thank you, Janice. As always, tons of great information. We appreciate all that you share with us and helping our little ones be the best that they can be. Thank you, everyone, and good night. And please share with others that they can go on and listen to this. This has been recorded, and it can be shared with any other parents that may be interested. Thank you, and good night, everyone.
Good night.